Bismillahirrahmanirrahim. Assalamu alaikum. Today's topic we are discussing on immediate loading, basics of immediate loading implant. In modern dentistry, patients' increasing demand to restore their teeth immediately after the loss is enhanced highly, and increasingly they depend on us to restore their teeth as soon as possible. And as we know, they don't follow our procedures for selection of treatment plan and all those things. The patient doesn't know all that. They fully depend on us to give them the teeth as soon as possible. So immediate loading is increasingly in our demand of dentistry, and on the basis of that, immediate loading, we are going to get the primary stability. Whenever we get the primary stability by using the implants, we feel more confident to restore immediately. So today we will discuss the factors which are going to be taken in consideration while choosing immediate loading in our practice. It's possible only when we know the basics of implant placements. Implant placement, we know the conventional ways. The conventional ways demand a lot of time for the healing period and osseointegration. So how to skip all those things and place the implant and load them immediately? This is what we are considering today. So the factors which are going to affect on the immediate loading protocol, we have to consider all those factors. Among those, number one is going to be the patient selection of a patient. So we have to select the patient which should be cooperative, willing for surgery, then good health and other factors we know. Then we need certain radiograph and other data collection to decide what type of implant and which areas we are using to place the implant, to achieve the knowledge about his bone density. So primary stability is the main factor for implant to be loaded immediately, and to achieve that primary stability we need bone. But as we have seen in our practice, that most of the cases which approaches to us has lost a lot of alveolar bone, and the bone depth and quality of bone or the bone width is not available. And periodontally involved mouths, they have real bone resorption, which restricts us to place conventional implants, either because of the position of the sinus in the maxilla or position of inferior alveolar nerve in the posterior mandible. So restrictions increases for placement of conventional implant. And on the other hand, conventional implant needs time to be loaded. We can't load. In most of the cases, we feel that we should wait for the healing period in conventional implantology. Now we are going to adopt immediate loading implantology. So for those cases which we are going to select for immediate loading are, most of the time they have no bone. So to achieve the bone knowledge, we can go for CBCT to find the bone density, location of nerve, and the sinus positioning, and other data we can collect from the CBCT and panoramic x-rays. Then after doing that, we should follow the second factor, which is going to be the availability of the bone. Availability of bone is less, so we are going to choose a different system of implant which provide us more stability, primary stability while placing the implant either in extraction socket or in the healed socket. So we need a system which allow us to achieve the primary stability by placing the implant in less bone, less quantity or quality. Both are lacking. And we are selecting a patient which conventional implantology is refusing to place the implant or asking us to perform more surgeries like sinus lift or nerve repositioning or considering other factors. So the conventional implantology patient demands early loading, whereas conventional implants, they are asking more and more time because of the surgeries involved. So the system which we are going to discuss today is based on using the basal bone. So the basal bone remains in our life forever. It doesn't resolve. One of the best thing about it is that it stays as solid, highly mineralized, and provide us real good strength for placing our implant. But to reach that basal implant, basal bone, to reach the basal bone during our surgery while placing the implant, we have to be very courageous, or we should be good, and we should have good knowledge and skills to reach the basal bone and engage our implant in basal bone. So they are calling is bicortical or engaging two cortexes to increase our primary stability so that we can load them immediately. This is the protocol. This is the basic difference between conventional and the basal implantology, is that conventional implants have been placed in the spongy bone or cancellous bone, which is more prone to resorption, and after teeth loss the bone is resorbed and we have very little bone to place the conventional implant. We need at least 8 to 10 mm depth to place the conventionals, and then we have to wait. So to fulfill our all the needs of our patient for immediate loading of implants, we are choosing basal implants, or other systems are coming to reach and engage the basal bone. So dental implant, when placed in basal bone, can be immediately loaded with teeth, as this bone is very strong and never gets resorbed throughout life, and forms the stress bearing part of our skeleton, as it is prone to stress bearing because of its highly mineralized surface. This provides us basic for the immediate loading. Since cortical walls around the extraction socket are very hard, they are also good site for placement of implants immediately. So immediate placement and then immediate loading is possible with basal implants, compressive implants. These are two types of implants which I have been discussing. We are discussing today for immediate loading. So basal bone, as we all know, the crestal bone and basal bone. The crestal bone is less dense in nature and is exposed to infection and from tooth-borne pathologies. So, but on the other hand, the basal bone is provide us good foundation to achieve immediate loading concept. So number of implants as well depend in placement of implant. Choosing the implant system like basal implant, we want to place number of implants to achieve the primary stability. In cases where we are using more than 3 or 4 implants, so we can splint them and achieve the primary stability of weaker implants. Few of the implants can be in a good bone quality of bone, like good bone quality is available, so we get good torque in certain implants and less torque in other implants. But if we splint all of them together and loaded them immediately with provisional processes, can help stabilize the less stabilized implants with the help of other highly torqued implants. So this is another concept of basal implantology. One of the factor is bone implant contact, and as we have less bone in the resorption cases, we are using the patients, we are choosing the patients with less bone. So how to place the implant, longer implants to achieve large bone implant contact. Large bone implant contact is going to provide us primary stability, increased primary stability and high torque. So, but we have lost the quantity of bone, and to achieve this bone implant contact, we can tilt our implant and place them at an angle. So the tilted implants or basal implants can be tilted. They are one body, single body implants, and they can be placed at different angles to increase the bone and implant contact, which in turn will increase the stability of our implant. First was to fix them in the basal bone. Second is to increase the bone and implant contact. Third is the bending. So these few factors which are possible with basal implants, as they are isoelastic, so we can bend them. Bending their abutment, we can increase the anchorage, and in turn we will achieve the primary stability, higher stability. So, and the other factors contribute towards primary stability are number of implants which can be splinted together. So they all can be immediately loaded. And then we have the surgical technique. Now this is very important. As with this type of implant, as I have told you, that we have to reach to the basal bone or the deeper areas in the bone. So we have to learn the technique, how to reach the second cortex, and first of all we have to identify the second cortex or the cortical bone or basal bone, where it lies and which bone we are going to engage. So implant site location, selecting the implant sites is very important, and then placing the implant in second cortex, maybe the nasal bone or the sinus floor or the distal maxilla. So you have to have the basic knowledge of the second cortex which you are going to engage, and the direction of your implant. So now confusing part in this system is that, as we have learned, the conventional implants, which are most of the time has been placed vertically, we rarely place them at an angle, and we use the angular abutment in that as well, but they don't prefer. Even then, if you prefer the conventional implant angle with angular abutment, you can choose, but to choose that implant you need bone, depth of the bone, which is not available in your case. So selecting a patient for immediate loading means you need bone and you don't have bone in your patient. So you have to select a system which can provide you the basics for immediate loading. As everybody knows, I think now they all are aware about the basal implants, how they provide the strength and primary stability and how they allow us to load them immediately. Basal implant, the modern system of implantology which utilizes the basal cortical portion of jaw bones for retention of dental implant, which is designed to accommodate the basal cortical bone region. So they have provided us an implant which is has certain qualities to achieve our goal of immediate loading. They are not wider and bigger implants because we don't have width of bone. The width of bone is lost and the depth of bone is lost. So all these factors can be covered through this system which is called basal implant. Now we are using three types of basal implant here. We want to discuss with basal implant, which is highly polished, fully polished surface implant. Then we have the compressive implant, which has surface treated portion, and then we have another implant which is TPI, 𝗄𝗏𝗏𝗏 implant. So 𝗄𝗏𝗏𝗏𝗏 provide us more and more stability, primary stability. And now I want to share with you guys a case coming to our clinic with all the teeth periodontally involved. He can't bite on them, they are loose and moving and difficult to chew, and aesthetic is also getting poor. So he wants to restore his jaw immediately. As you can see in this case, we have upper jaw, very less bone, soft bone, less bone, bone density is low, and we have to extract all these teeth, and he wants to restore it immediately. How to achieve that immediate loading in this case, where the sinus is so low, we don't have any bone? How to bypass our sinus? This we have to learn to achieve primary stability in the immediate loading cases. So how to bypass sinus and how to bypass lingual inferior alveolar nerve, lingually or buccal bypass, the two bypasses systems we are going to discuss. They all are supposed to be well skilled surgical protocol, and you have to develop that surgical skill. First you have to learn how to do it, and then you have to engage them in the second cortex. You have to focus about the second cortex. So after extraction of this case, how we can fix the implants and then load them immediately within 72 hours. Patient wants teeth. So in such cases, we have to extract all the teeth and choose the areas which we have to learn which areas are supposed to be strategic for placing the basal implants, and then we can load them immediately. Definitely we have to load them with a temporary teeth for the period of shrinkage of the extraction sockets. That has to happen, and then after shrinkage you can load them with the permanent prosthesis. So immediately you need to place implant and then splint them, then load them. So but the crestal bone is not that strong. After extraction, the crestal bone is less dense in nature, exposed to infection and injuries and peri-implantitis. So all these factors doesn't allow us to put conventionally in this case, as the bone availability is quantity and quality, both are low. But as we have talked, that basal bone is always available, but it is way deeper into the jaw depth, and you have to go deeper, you have to drill higher to reach that basal bone. Pointer. So, then we have to see next slide, and after that we will conclude this case. Like for example, this is another case. See, the maxillary sinus is lying so low and you don't have even 1 or 2 mm bone over there, and the patient doesn't want to go for sinus surgeries, or even in the lower jaw you can see how much bone resorption is there. So selecting such cases for immediate loading, you need a system of implant which allow you to place the implant and load them immediately. So this is our goal, and which we can achieve with the help of basal implantology or cortical implantology. So gaining the primary stability is the prime concept for immediate loading. So to achieve that primary stability, you have to choose longer implants, but bone is not allowing, bone is less, so you have to have a tilted approach. Tilted approach means angular implants. You have to place at an angle, not straight, not vertical. So to reach that goal, how we will achieve? I have placed a slide for you guys. That's pterygoid implant. For example, we are using the distal maxilla, and for using that distal maxilla, we are choosing the pterygoid plates, the fusion zone of medial and lateral pterygoid. So placing that pterygoid implant, it has to be at an angle, it can't be vertical. As you can see in the slide, it's placed so angular, and placing at an angle or tilted angle can provide you the placing a longer implant. Placing a longer implant means you are increasing the bone implant contact and you are engaging it deeper into the second cortex. So bicortical implantology, you are achieving the bicortical implantology here. See, this is our pterygoid region, and we are approaching from third molar area, tuberosity area, at an angle 30 degree to 45 degree to reach that cortex, second cortex, and that is the pterygoid fusion zone. So after placing this implant, you have to bend it, and once you start placing pterygoid implant successfully, you will find that the primary stability is the excellent primary stability in this region. This primary stability, when you achieve at the second cortex, see these white lines, they are the second cortex, and the first cortex is right here where you start drilling. That's the crestal part of the jaw. So this is the first cortex and that's the second cortex. And even in other cases you can engage multiple cortex. So engaging multiple cortex is a technique to gain good primary stability, which is the most important part in the immediate loading technique. We will inshallah discuss and train you in our courses, upcoming course as well as other courses. We have performed few other courses in the early days in this year, 3 courses I think, and we have taught and explained on models how to reach the second cortex and how to engage the implant to achieve primary stability. We will do it inshallah in the course. Today we are just discussing to achieve immediate loading concept and to fulfill patient's needs. See, for example, this is a patient which have resorbed mandible, resorbed maxilla, whole of the upper sinus is lying here at the ridge, on this side as well. You don't have enough bone to place the implants, and the rest of the teeth, they are, even in the lower jaw you can see, all are moving, the bridges are loose, the periodontium is not good, the periodontally involved teeth. So we have to extract all these and place the implants. And patient wants immediate loading, fixed teeth. They want fixed teeth with immediate loading, implant placement. Okay, they don't want 4 to 6 month waiting period or 2 or 3 surgeries. So we have to learn how to find the basal bone and how to use it. Why? Because the basal bone is harder, stronger, stiffer than cancellous bone, and it's almost free of infection, and it's almost free of resorption. So we have to learn the way and technique to reach the second cortex. Now this is the case which has been restored after inserting the implants, and patient is happy. Within 72 hours they have provisional teeth, and after healing of the sockets you can change the processes to permanent restoration. Another case, so case selection is very important. Most of the cases, they will come where the surgeons has refused them that we can't place the conventional implants, or if we can't place the conventional implant, then they want to do more surgeries like sinus lift, bone graft, and all those surgeries, and then after that they have to be restored. But patient is looking immediate loading. So again, you can choose. You have to have that technical skill to be learned somewhere to perform these basal implant techniques in your patient. And to provide that platform, we are introducing academy here, which is providing courses, Academy of Basal Implantology here in Karachi. So you can join our courses, and we will train you inshallah to perform these surgeries and to learn the basics as well as advanced parts of this technique. So to learn this basal implantology, we have to learn the basic concept which are anchoring our implant. So anchoring our implant in basal bone is one of the key factor here. And to learn the basal implants techniques, we are providing certain X-ray cases. Here another X-ray, you see all broken teeth are present. So we have to extract and place the implants immediately and load them immediately. These all cases can be restored with our technique of basal implants or bicortical implantology. Look at these implants placed at different angles. These are the techniques you have to learn for this immediate loading. Placing implant at different angles and then bending them and making them straight in the arch. It's an art. It has to be learned, and once you learn, you will enjoy this feeling as well as restoring your patients with teeth immediately in 72 hours or so, as depend on your labs. See, now we are discussing the segments. You can place implants for such cases and load them immediately, but again we are asking you to learn the skills of immediate loading. Here we can place few implants to engage this area in this angle, 2 or 3 anterior to sinus, and bypass and place one or two implants posteriorly to in the pterygoid region, and then you can restore them with the bridging technique. Now see the lower jaw. This is another interesting case. Here we have to extract all these teeth, the mobile teeth, then see at the posterior mandible. We don't have enough space there. The inferior alveolar nerve is not allowing us to go and place the implant conventionally. So limitations of conventional implant can be overcome with the help of thin, long basal implants, and they can be placed at an angle to increase the length. For that, for example, see in this implants we have placed at an angle of about 45 degree and then bended them to get in the arch, and see lingual bypass in this, then again bended. This one is straight, but because it's thin implant and it's been bypassed buccally. So buccal bypass, lingual bypass, these all are the terms you have to learn and you have to practice. We are providing you a workshop here as well to learn the lingual and buccal bypass technique and hands-on technique. You can place them on the models and then you can learn them. For that you have to learn the inferior alveolar nerve canal and the mylohyoid ridge and how to place bypass, how to bypass this nerve and engage the implant in the shelf of mylohyoid ridge. So this all is technique sensitive. So to learn and practice immediate implantology, you have to learn the anatomy, you have to learn hands-on techniques. So finally you reach to bicortical engagement of your implant, which is a single piece implant. Advantages are, a lot of advantages are there for providing the immediate loading or the basal implant, as few surgery like less invasive procedures, just one drill, and you are engaging your implant. Post-operative, less complaints of post-operative, like you don't have to worry about your patient because less invasive surgeries, and you are not grafting, bone grafting is not required. So one of the advantage of this basal implant is the self-cutting threads. They engages the cortical easily, and the other advantage is that they are thin and they are bendable. You can bend them and you don't have to do another surgery for placing the abutment. So all these benefits, see how you are achieving immediate loading with all those benefits giving to your patient. And we are announcing a course here in our academy for master course, which is in December. Anybody who wants to register, these are the numbers, and they want to learn this system, we are glad to provide you the platform to learn these skills and techniques to add this in your surgery and provide your patients to perform the immediate loading. And here we will discuss a lot of technique, surgical platform. We'll provide surgical platform, we'll provide hands-on platform, we'll provide lectures, and finally question answer sessions are open for everybody in the course, so you can ask any query, and you can, even after the course, you can continue your learning through our other programs and contacting us on the WhatsApp, so that we can provide you case selection, help out in case selection, then treatment plans for segment cases, treatment plan for full mouth rehabilitation, but it's very technique sensitive. It looks easy, but you have to learn it, and to learn it you have to have basic knowledge, which we are going to provide, inshallah. Today was the introductory session, and this introductory session, I believe I have covered a little bit of basics for you guys to understand the immediate loading technique. So this is the basic phenomena, and we all are here to finish this course for you in December. We'll finish and we will perform. So I hope you have learned basics of immediate loading. Thank you.